This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, and welcome to the Neurology podcast. This is Dan Ackerman from St. Luke's University Health Network in Bethlehem, Pennsylvania. Today, I have the pleasure of talking with Isabel Hostettler. Isabel is a consultant neurosurgeon at Hog Health in Ostweiz, which is in St. Gallen, Switzerland. Isabel, thank you so much for joining us today on the podcast.
Thank you very much for having me.
So today, we're going to talk about a paper on which she is the first author, titled Outcomes After Reversible Cerebral Vasoconstriction Syndrome with Convexity Subarachnoid Hemorrhage. This paper can be found online and was also in the August 2025 print version of the Green Journal. Isabel, I have to say, I love this because it turns out not every thunderclap headache is an aneurysmal subarachnoid hemorrhage, much to all of our chagrin. We drill that so much, but sometimes it's something else. So just to make sure we're all on the same page, tell us, what is RCVS? How do we diagnose it? And what puts people at risk for it?
So me as a neurosurgeon, I'm very primed on ASAH, so on aneurysmal subarachnoid hemorrhage. But as you say, it turns out there are other kind of subarachnoid hemorrhage. So RCVS, as you said, reversible cerebral vasoconstriction syndrome, is essentially a condition where the brain's arteries go into spasm. We call that vasospasm. This is not a feature unique to RCVS, but it's one that defines it. The hallmark clinical feature is recurrent thunderclap headache. The patients that describe it, it's very unique. Even patients who have migraines, who are used to have severe headaches, they say this is something they never experience. What's fascinating is that we see this most often in actually younger patients, so typically under the age of 60, and women are affected much more commonly. The diagnosis has two key components, I would say. First, you need to see vasoconstriction on vessel imaging. This could be CTA or MRI. Of course, you can do that in a DSA as well, but that's more invasive. And this is the critical part. It needs to normalize on follow-up imaging. That reversibility is what makes it RCVS. That's what gives it the name as well. Second, you need to rule out other mimics through comprehensive workup, like CSF analysis for vasculitis or other things like the imaging, like we mentioned. Aneurysmal subarachnoid hemorrhage is a differential diagnosis, which is very important to differentiate, as the prognosis of ASAH is very different. As for other risk factors that we can mention, there are drugs who are risk factors to cause it, and this is something patients don't like to hear. There are also vasoactive substances like cannabis, cocaine, or even over-the-counter decongestants that can cause it. Or we see it also more frequently after the postpartum period, so after a woman gives birth. The key thing really is to recognize that the thunderclap headache pattern is there, and then to get the right imaging in order to make sure that you don't miss out on other diseases, and also to be actually able to make a diagnosis.
All right, there's a lot to unpack there. Let me just make sure I have this straight. So RCVS is typically non-infectious and, as far as we know, non-inflammatory. Is that right?
Correct. Yes.
And we're talking about thunderclap headache, but most often recurrent thunderclap headache. And then evidence of vasoconstriction that we think is due to arterial spasm, but we have to show that is reversible. Is that right?
That's correct as well, yes.
Remind me, the time frame is, the reversal has to be within, is it 12 weeks?
Yes. So when you read the manuscript, these 3 months that we used, where I will most likely mention that later as well, progression versus a true recurrence, this 3 months were not just used because we thought it's a great time frame, but because the first episode, or the typical episode, is over after 12 weeks, after 3 months. So it should normalize after that, although symptoms improve more quickly.
Two other quick points I wanted to focus on. First, in your paper, these patients had RCVS, but also convexity subarachnoid hemorrhage. Could you just describe for us what is the typical appearance or presentation of convexity subarachnoid hemorrhage due to RCVS, as opposed to, say, typical aneurysmal subarachnoid hemorrhage or perimesencephalic subarachnoid hemorrhage, some of these other non-traumatic causes?
So cortical SAH, convexity subarachnoid hemorrhage, is quite localized. In CSAH, the bleeding is usually confined to one or more sulci of the brain without really extension into adjacent brain parenchyma, for example, or the fissures. And it's not in the basal cisterns, and you shouldn't see any blood in the ventricles. Again, in aneurysmal subarachnoid hemorrhage, for example, you have much more blood. You have blood everywhere around the brain. You can have blood in the brain parenchyma as well, which is called an intracerebral hemorrhage, ICH. You have blood in all the basal cisterns and again in the ventricles. When we talk about CSAH, RCVS associated CSAH, it's not that rare. It happens in about 20 to 30% of patients who have an RCVS. So it's actually quite common.
Wow. So we are seeing this reasonably frequently in our RCVS patients. The other point I was hoping to bring out based on the paper itself is this was an outcomes study. Again, just tell us a little bit what events you selected as primary outcomes. And we touched on this a little bit earlier, but if you could help me understand the difference between an episode that is considered progression in a patient with RCVS, since this is an episodic and potentially progressive condition, as opposed to someone who experiences a recurrence.
So we had different outcome variables. Our primary outcomes were recurrent convexity subarachnoid hemorrhage, which might sound strange. After RCVS associated CSAH, have higher risk of having another CSAH. Just so people don't get mixed up and think that this is something we mentioned by mistake. This is actually true. But now here is the crucial distinction that we need to make, what you said about progression versus recurrence. And this is really what changes how you interpret. We separated the events that happened before 3 months from the events that happened after 3 months. Why 3 months? Because that's the accepted time frame for an RCVS episode, as I mentioned before. So the vasospasm typically resolves within weeks to 3 months. And if it hasn't resolved after 3 months, you have to go back to the starting point and reconsider other possibilities. Events before 3 months, we called these progressions. They're part of the same disease episode while the arteries are still in spasm. And events after 3 months, this is what we call recurrence. Something new happening after this disease has resolved or should have resolved. This distinction matters enormously for patients counseling, for example. If someone asks you, what's my risk of having another stroke? That depends on whether we're talking about the next few weeks while this is still active or next year after everything has calmed down. The risks are very different. This is something that patient needs to know. We followed up patients over 5 years in total, and we saw that the events that we had were most frequently in the beginning, so in the progression period rather than the recurrence period, which means that real events that happens after the first time frame, so the first 3 months, are very rare in these patients, which is a great thing to know for patients and their relatives.
So 3 months is that inflection point, and that's going to help us determine the difference between our progression or issues related to progression versus issues related to recurrence. And considering those primary outcomes, now we're all primed up. We all have a good baseline understanding. So what did you learn about those primary outcomes in patients that have convexity subarachnoid hemorrhage related to RCVS?
The headline and the really reassuring message for patients and their relatives is that this condition has a very favorable prognosis once you get through that initial acute phase. And even though, yes, you can have some events during the progression phase, the functional outcome was still very good. We talk about the MRS, which is the Modified Ranking Scale, And this was still good even in patients who had a progression. So when we talk about the annual recurrence rate for each of our outcomes, so CSAH, ICH, and ischemic stroke, this was less than 1% per year. So that's very low. We're talking about 0.81% annually for each. But here's what's really striking. When we separated progression from recurrence, we saw that most events happened very early. So in CSAH, 10 out of 12 events occurred in the first 3 months. And for ischemic stroke, it was very similar, 8 out of 10. So what does this mean practically? During the acute phase, that's where you need to be more vigilant. That's where progression can happen. But once patients get through that initial period and the vessel normalizes, the true recurrence is actually quite rare. And here's perhaps the most important finding, what I meant with the modified ranking score. 94% of patients in our cohort achieved a functional independence, which is measured as a modified ranking score of 1 or less, meaning no significant disability. That's, for example, something that you don't get of other forms of stroke. More importantly, I keep on mentioning the aneurysmal subarachnoid hemorrhage. That's probably because I'm a neurosurgeon. But there is something called the cerebral amyloid angiopathy-related convexity SAH. We have another manuscript, a paper on that. And they do have much higher rate of events of ICHs, ischemic stroke, and also of convexity subarachnoid hemorrhages. So overall, I know it's very difficult to tell patients and relatives that, hey, if you consider everything, you actually have a quite favorable disease, but I do believe that we can say that.
I think that is huge, particularly when we are talking about subarachnoid hemorrhage. And we've all been in, or so many of us have been in the situation of watching someone with an aneurysmal subarachnoid hemorrhage for 3 weeks while we are hoping to avoid vasospasm. And if we do see evidence of delayed cerebral ischemia, scrambling to try and help out. And it's such a prolonged process. But being able to say, yes, this is stroke, it is subarachnoid hemorrhage, but with these characteristics, we've got a very favorable prognosis, and especially to be able to put a time frame on it and say, if something is going to happen, most likely we're talking about in that first 3 months as a matter of progression rather than recurrence. So many of my patients in clinic come in with a little bit of that deer in the headlights look, feeling like they're a ticking time bomb. They're just waiting for something to happen again. And so to be able to offer that reassurance is just outstanding.
Totally agree. That's a problem with Google, or we say Google, any search engines. They're amazing and they're great. And if you tell me something, I'm someone who has to Google everything. But the problem is, if you do that without any background, and I see that in things that I don't know much about, if patients do that and they just Google subarachnoid hemorrhage, the first thing you hit is usually ASAH. And then, as you say, they come with big eyes, they're worried for their lives. And first I have to tell them, this might sound strange, but you actually have a quite benign form of subarachnoid hemorrhage.
Anytime we say the words subarachnoid hemorrhage, the word benign just doesn't really come to mind very often.
No, absolutely.
Now, all retrospective studies, they give us outstanding data. They all have some potential limitations, and most of those have limitations that are quite common between them, including this one. But there were some unique strengths to your particular study. Tell us about those a little bit.
It actually is, as far as I'm aware. I haven't Googled it or PubMeded it in a while, but it's the largest cohort of RCVS-related convexity SAH with long-term follow-up data. We did pull individual patient data from 9 international centers. There were 21 studies or centers that could have been included, but as we all know, some people do not reply, some people actually do not want to take part, and they miss out, or you miss out on being able to include their patients. But overall, this is much more powerful with that pulled individual patient data analysis than just combining and publishing summary statistics. So, for example, just a review or just a case series. And our sample size of around 100 is the possibility to give more precise estimates of these relatively rare recurrent events, CSAH, ICH, and ischemic stroke. And more importantly, we had a pre-specified protocol that all centers agreed before contributing data. And in a retrospective study, everyone will say, yeah, you didn't do that beforehand. And I totally agree. And I'm not saying that to make it sound better, but that's for a retrospective study. We tried to make it as good as we could. We tried to standardize what we could. Of course, we couldn't standardize a follow-up. That's why we had such a huge range if you read the manuscript. But this standardized the case definition and ensured talking about the same thing at least. Even it starts with a definition. What is defined as we started in the beginning? What is a CSAH? And some people have a bit of a misconception, although I would say not neurologists, and I hope no neurosurgeons anymore, but this is where it starts. So I don't want to make it sound our limitations, and you do see that we don't have follow-up data on all patients, but we 70%. So overall, this kind of collaborative individual patient data approach is really valuable for rare conditions where no single center sees enough patients to answer these questions reliably. That's what I think. We couldn't have gotten these estimates in other ways. And yes, everyone likes to say as a last sentence, our aim or goal and our next project is to collect a bigger cohort. I think this is going to be a bit difficult in this disease because it is so rare. I do believe that this is a very strong point of our study.
I agree. And first of all, on behalf of all neurologists everywhere, we appreciate the compliment. Thank you.
Very welcome.
It is rare, and assembling not only the significant number, but really reaching out and assembling this sort of international collaboration, really trying to make sure that we can look at data like this and have a reasonable expectation of this generalizing, or at least understanding how this can generalize to the patients that we're seeing from day to day, from week to week. With some of the most innovative studies around, one of the things that has stood in the way of adopting some of the information is that question of generalizability. And yes, that's a great conclusion, but does it really apply to the people that I'm seeing? And so addressing the kinds of questions that we're really asking, concern for recurrent subarachnoid hemorrhage, future intracerebral hemorrhage, ischemic stroke, mortality, overall modified Rankin, looking at the kinds of outcomes that are really of interest to the neuroscience community, and assembling this number of patients is just a huge step forward. So thank you for doing that. Isabel, could you just remind us a little bit more or elaborate a little more on those risk factors? You mentioned certain medications can place people for RCVS in general, and of course, in this case, at risk for convexity subarachnoid hemorrhage. And I believe these are some really common medications. This is not some exceptionally rare monoclonal antibody that we're not going to see. So just, if you don't mind, tell us what kinds of medicines will put people at risk.
Yes, absolutely. I thought of saying it and then I didn't want to cause any panic. Actually, as you say, very common medication can cause it. The one that when I read it, I thought you can't really say that because a lot of people take SSRI. So SSRI are risk medication for RCVS. So SSRI, antidepressants, very common antidepressants, they're actually a risk factor. Somatriptan. So somatriptan, patients who have migraines, they might take that. And this is, I don't know the word in English, it's in German. It's very not nice because you take something to make a very bad headache better, and then you get another very bad headache. These were the two outstanding medications to me. Of course, you have other medications, as you mentioned, rarer ones like cyclophosphamide or, tacrolimus, but not so many people take it. I would say SSRIs are the most common ones, in addition to recreational drugs such as marijuana. But if you're into sports, for example, and you take EPOs or erythropoietin, this is something that is a risk factor for RCVS as well. So you need to be a bit careful of what you take, not in the meaning that you shouldn't take these drugs, but if you experience side effects from them, and this side effect might be a thunderclap headache, that's where you have to start thinking maybe it caused it.
I completely agree with you. And although RCVS remains a relatively rare diagnosis, the things that place people at risk are quite common. On the one hand, that's a little bit reassuring, given the number of people who are taking serotonergic medications and the like. Given that number of people, but the ongoing rarity of RCVS, it at least brings some hope that it's not a common complication of these medicines. But it does mean that as we are dealing with patients who have convexity subarachnoid hemorrhage, patients who have thunderclap headache, some very simple and very common things can be the thing that puts someone at risk and puts them over the line to get this condition. That can be a difficult conversation to have for sure. And I think you've painted this picture already, but I just want to drive this point home. So for the average neurologist or neurosurgeon on the street, the conclusions in your study, how should they really inform and guide our treatment for patients who have RCVS and convexity subarachnoid hemorrhage?
So I really believe that you can reassure patients. When someone comes in with an RCVS-associated convexity SAH, they're understandably terrified. As you said, they're the deers in the headlights. You can tell them, yes, we need to watch you closely over the next few weeks, 2 months. This is active, but once we get through this acute phase and your vessels normalize, your long-term out is actually really good. And you might not need to say specific numbers, but this, for patients, this is what I've experienced already very reassuring to hear. Second, it reinforces that the acute phase is critical, that there is a differentiation between the 3 months and after 3 months. If a patient passes the 3 months, this might be over, that you might not re-experience it again. Although I've been working as a neurosurgeon for 15 years now, and I've seen 3 patients who had recurrent RCVS-associated CSAH. Rare, but yes, you can see it. And then that's where we come to the what do we do on the long-term question after the acute phase is over. So you can help patients who usually want to come back in again and again because they're very terrified, they're afraid, they're worried that this might happen again. And this is very understandable. I would have been the same. And if you want to compare yourself to a comic figure, I'm Melman from Madagascar, so I'm a hypochondriac. I'm the first one who's, I'm going to die from this for sure. Well, no, I don't believe that anymore, because I know after the acute phase is over, the recurrence risk is extremely low. And finally, our study highlights that RCVS-associated CSAH is fundamentally different from other forms of subarachnoid hemorrhage, starting with the aneurysmal subarachnoid hemorrhage, going to CAA-related CSAH, or subarachnoid hemorrhage from other reasons, like a ruptured AVM or like a severe trauma. Same imaging appearance on CT, but completely different prognosis. So for once, we can actually tell people do not worry too much about it. And the bottom line is that even though you might experience symptoms now, and they're quite severe, we don't say that they're not, and we do take that very seriously, and we believe it, but we can reassure you that generally the long-term course, and I'm not sure I'm allowed to say that, but it's benign.
That is outstanding news. And anytime you can have something like subarachnoid hemorrhage, which strikes fear into the hearts of patients and clinicians alike, to be able to say, but wait, we know what to expect. We have an idea here, and people can really do very well long-term is wonderful. So to check out the full paper, Outcomes After Reversible Cerebral Vasoconstriction Syndrome with Convexity Subarachnoid Hemorrhage. Isabel, thank you so much for joining us and talking to us today.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.